and love developing interventions. All my PhD students develop interventions. Um, Love to test them. We've been more recently in the last 10 years using RCT methodology and its application to this population. But I don't know how much of my research ever gets implemented. I would say I've struggled with that because that's not my job. My job as an academic, as a researcher, so I sit in an ivory tower. That's up to clinical staff like social workers and nurses. And I think that's been the challenge. So whose responsibility is it to try and get research implemented? And obviously, the frontline staff say, "Well, we don't know about research. That's your job." So there's a grey area, and I think the funders are now starting to say, "Well, if we're going to fund research, you as researchers need to have a plan in place to get it embedded within practice." So this is this is where the science of implementation has come up, and it's been around for years. Like you said it, um, and it's transfer, knowledge transfer, not mobilization. It's been there for years, and it's in lots of different areas. But somebody very wisely decided, well, let's make a science of it and let's get some people some jobs out of it. So I've been very lucky. I've been one of those people who've just took a post up on the 1st of January. So I intend to do three things, or actually three things, yes. The first thing I want to do is try and give you a little bit of understanding from, how do we go from research to implementation? And then what is implementation science, implementation research, and implementation practice? And then in one of the grants, I want to use particularly this third. So the first fourth of the talk, third of the talk will be a wee bit of that academic stuff we have to do. But this is the application of it. So how can we use implementation science to understand a project that didn't go well at all? So we got £2.1 million. In fact, we just got another £300,000 of extension to undertake a study around adults with learning disability and diabetes, and we couldn't get it implemented within clinical practice across the UK. I'm going to share how we're now rethinking about what we can learn from that. What are the barriers to implementation? And then what would be some of the strategies to try and get that research into practice? Hopefully it's exciting. Hopefully you'll not be too freaked out by some of the language. So I'll try and keep it as simple as possible. And I realise we only have about 40 minutes for a chat, me talking and then having a chat. So in my field then, I'm going to refer to intellectual disability because that's the term we use across the UK. So we get, as researchers, as Brian and I, we get money to take research. It gets us to lovely conferences all over the world. We get an opportunity to complete papers, chapters, book conferences. But what happens next? Whose responsibility is it to take the research into clinical practice? And I think that is really, the ref that we have at universities is all about what is the impact. And maybe 20 years ago, it was worth 5% of the money. Now we have to show, I think it's 35% that we have to show. How do we get our research into practice? Because we just publish and we put it on the shelf. Is that the end of it? So this is what this talks about. So what is implementation science, first of all? So it's the study of how to adapt and embed the latest evidence, so policies, interventions or programs, technologies, or new clinical practices into routine care. So we want to move this evidence-based thing and we want to get it into clinical practice wherever you work. Implementation science provides like frameworks or tools or strategies to help you support this change in the context that you work. And that word context is very important because I think for years we just thought we could take an intervention, tell you that it works, and then it should be implemented across every setting. And that's the challenge here because every setting's not the same. Every setting has different actors, has different leadership styles of different types of people, different types of patients, and they all interact differently with different resources. So we see context as very, very specific. I just want to flick here. And it helps you to overcome the real world challenges, the barriers, the implementing evidence into practice by identifying different strategies. So we want to look at the barriers in your context, given that every context is different. And then we want to together, we do this together, all in co-production. Um, we want to look at what would be some of the implementation strategies, those effective implementation strategies that would help you to get that evidence into practice. So that's basically what implementation science is in a very user-friendly format. And it really does bridge the gap between evidence, policy, and everyday practice. So this is just the definition. It's a pretty boring definition.
Lauren, sorry to interrupt. Let us know when you want to share your slides.
Am I not sharing them?
No, you aren't.
Oh, yes, sorry.
Yeah.
Will you make me share the next one then?
Yeah, thanks.
I thought I had the power, but anyway, no power today. Okay, so you've got the little picture. So basically, you can see in the picture, in the diagram on the left, this is where all the research works out. And then,
Lauren, Lawrence, can we interrupt you again? Can you try sharing again? Because I think maybe we disrupted you at the start by you had yours on the screen and then you took yours down. So could you reshare them again? Because we're not getting anything.
Okay.
And I know I know you'll share them and people will get them afterwards.
Yeah, no, I'm trying to stop sharing. Let me just see. Can you see that now? No, obviously no.
No.
Okay, give me a wee second. Why am I not even? I can't even stop sharing.
Do you have two screens?
No, just one.
No, just one. Sorry, because sometimes you can open another.
Okay, I think I said no. I'll stop sharing. Can you? Yeah. Okay. Let me just see if I can share. I'm going to try and share here.
Something's happening.
So do you see my screen now?
Yes. And
yeah.
We've got from the first one, I think you haven't it on.
Yeah, that's okay. So
yeah.
Okay, so you saw that slide, what implementation science is? That was me just giving that definition.
Yeah.
Okay, so basically, so you can see the next slide then. It's just black and white. Yeah. So basically, I love this diagram. So basically, you have this is on the left-hand side, you literally have all the research that takes place, whatever it is, qualitative, quantitative, co-production, right? And then we jump over to here, and and then we're looking at, what is the final outcome? And we just pray. It's like a miracle. We hope a miracle will go from this research to this final outcome. So implementation science is the scientific study of methods that promote the systematic update of research findings and other evidence-based practices into routine practice to improve the quality and the effectiveness for patients and for services. That's the scientific term by Annette Brewer in 2015. So how can implementation science approach help you in your work? I think we hear about examples of research interventions. I don't know what they're specifically are in intervention, but even things like CBT or mindfulness or parenting programs or systemic family therapy, we get that evidence of what works. We hear about its outcomes, and we may sometimes hear about, yeah, that's good, that's really, really good, but we can't implement that, because we don't have enough capacity and capability, or we don't have enough resources. We were with the Department of Education yesterday. We've been doing some work with a PhD student around dyslexia training for classroom assistants. And it was a 3-year PhD sitting with the Department of Education. They loved it, absolutely loved it. But we can't implement it because we're in £300 million worth of debt, and the school meals have just went up 50p. So schools are under pressure now. That's a big barrier. So we've got a bit of evidence that works, that could really help children in the long term, but we just can't get it implemented. So that's the question. That is the most, yep.
Lawrence, when you say research interventions as opposed to embedding them in real world situations, are you referring to interventions that are tested under some kind of optimal conditions?
Well, we're just saying, if you have an intervention that it's some sort of evidence base, that's what we should be looking at. There's a lot of interventions out there that may not have a theory underpinning it, or they may not have a really good, strong evidence base. And that's what we need to look at, So we're sort of assuming in implementation science, you're sort of assuming that you have an intervention or you have a policy. and you want to implement it. Sometimes it may not be the strongest of evidence, and that's okay. But we're sort of way looking at it. If you know something works, then the question is, how do we implement it? Because if you don't know how it works, well, it mightn't be the right intervention, or maybe do a little bit of work on that. So the critical question is, how do we actually make these interventions, policies, technology, practices happen in social work practice? So evidence alone isn't enough. Like, we do a lot of training, but training alone will not change people's practice. Changing generally will change people's knowledge and attitudes, but it may not necessarily change how people work in practice because of all the challenges that's around them. So the challenge is then, sorry, I'm just moving your screen, we'll take that off. I can't, it's blocking me, that's okay. The challenge is how do we make it work? How do we get this evidence and make it work in practice? And how do we scale and spread the evidence? So if you're working, let's just say you're working in Limavady and you've got a really good bit of evidence, how do we scale and spread that across Northern Ireland? Making sure that that intervention stays the same, the fidelity of it. How do we scale and spread that across the UK? Multiple social workers, multiple managers, multiple different ways, rural or urban. You know, how do we scale and spread that, and how do we sustain that as well? So, and I think that's where implementation science comes in. And the funders now, like the NIHR in the UK, the National Institute for Health Research and the National Institute for Health, are starting to realise that whenever they commission research, whether it's a randomised controlled trial or a non-randomised or some form of evidence, some form of research, there has to be embedded with it an implementation strategy or a strand. And that's what they're looking for in funding going forward. So, in my words, implementation science is concerned more with how it works, where it works, and why it works, as opposed to simply saying what works. So we're going beyond this, and there's the evidence, and then trying to help practitioners understand how it works, where it works, and why it works. Okay. So let me give you an example. Okay, very, very simple example within universities. In universities, we develop an intervention. We do discovery research. We may do some preclinical. We may identify a policy or an intervention. That's the what works. And then we go, do we test it? Okay, we test something in a as much of a controlled environment as possible, either through a definitive randomized controlled trial or some sort of pilot studies. We try and say, does it work in ideal conditions? And then we look at patient outcomes. Okay, and that doesn't always carry through. We just know sometimes it works, sometimes it doesn't. You know, there's something going on here that is just not just straightforward. It's just not as linear as what we would hoped. And I think what we're trying to understand now is that we need to understand how patients, how families, how communities, how hospitals, how schools, how community teams, we need to understand how they work at their local contexts. And I think that's been missing for many, many years. We did it at university. We developed an intervention on some theory. We tested it through an RCT. That's perfect. And that should be ruled out. And it's not as simple. And I think this is what's happening now. The funders are recognising there's really been an underuse of implementation science theories, models and frameworks to take this bit of evidence and to get it into public healthcare service delivery. And in fact, I would also say in the past, we would have did the discovery research, the testing, and then we would have thought here, let's look at implementation as an afterthought. We never built implementation science into the discovery research, and we definitely never built it into testing the research. And I think that's been one of the challenges, and that's where our thinking is now. When we start to think about developing an intervention and testing it, even within an RCT, we want to embed some of the implementation science theories, models and frameworks. So like I'm saying to you, there's a massive gap between knowledge or research and between practice. And we think this is where implementation science can come on board. Now, I'm going to finish in this one slide and then I will take a pause because there's a lot to take in there and I need to take a drink of water. So like I'm saying to you, what works? Does it work in work in ideal conditions? And we realize, you know, randomized controlled trials are a bit false because you're controlling. But now what we can do is we can bring implementation science into the real world, even into these testing environments. And we can ask, can an organization accept this evidence-based intervention? Can it adopt this intervention? You can't just lift the same intervention and deliver it everywhere around the world. That's not going to work. You have to adapt it according to your context, to your population, to your staff, to your resources. Can the fidelity of the intervention be sustained? So we know that what parts work are still being delivered even with some adoption. What is the cost to the organization? And can it be sustained long term? And obviously we want to check out, yes, does it have an impact on the people we care for? Does it have an impact? Does it have a benefit for the service you work for and the wider society, like NHS, like sickness and access to treatment services and hospitalization, all that, and early death? But now, for the first time, we want to look at how do we measure implementation outcomes? And we can do that through both qualitative and through quantitative research. So we want to ask, if an organization is taking the intervention, and going to put it in their real world setting, we can actually test how are they implementing it? How are they getting on well with implementing it? Or are they not? Let me give you an example. One of our students, Anne Johnson, developed a walking program for children with learning disabilities. It was around pre-COVID, which is not a good time to do a randomized controlled trial. But anyway, we went into some schools. Some of the schools delivered it the way we did. It was meant to be 2 classes. Older children with learning disabilities were buddying up with younger children. We went into a classroom in another school and they says, no, COVID says you're not allowed to mix people together. So they've all the children just walking together as a group. Now, that doesn't tell me if the intervention works. That just tells me it can't be implemented. We had another school and they live near a big walking, like a racetrack, walking track, sports facility. And we thought, great, happy days. You know, whenever the children would come in, they could come up by 10:15, they could go do the walking. And the school says, no, the bus drivers get their 45-minute tea break. And if you try and do this, the unions will be upon you. That doesn't tell me if the intervention doesn't work. It just tells me there's implementation issues. And that's as simple as I can make implementation science. You know, but we want to build implementation science into how an intervention works. We want the researchers to think about not only how an intervention works using behavior change theories, but we want to now look at individual or systems change theories. We're talking about how organizations work, whether that's a school or a ward or a hospital or a social work practice. We want to get down, we want to try to understand context, and we want to build that in to how we evaluate something. I'm going to stop there. If you have a question, you're welcome, or if you want to hold it to the end. Happy enough to go on? No, go ahead. Yep. Hidra?
Yes, Lawrence. Can you give us some examples of studies that proved to have the intended effects in RCTs, but which also gave the expected implementation, service, and patient outcomes?
So what I'm going to do is I'm going to actually give you a real live example in a wee minute of a study that we're taking in at the minute, and that'll answer that question.
Okay.
Is that okay?
Thanks.
So I all realize when you give this, you know, implementation science, even our terminology is not great. I think it's madness. In fact, the Netherlands have produced, I think it's a brilliant, they have a new professor, and they're a professor of failure. So And that's very similar. That's part of my job. I like to look at what works, but I like to know what doesn't work. You see, if you only find out what works, you'll get a p-value, but it don't tell you what components work or doesn't. It just says it has interventions effective, but it doesn't tell you where or what. Where we try and get into the nitty-gritty, the more granular. Okay, so why is implementation science needed in social work practice? It bridges that gap or closes that gap between disability evidence and clinical practice, whatever it is. Okay, it addresses the 20-year delay from research to practice. So a lot of people would say we would do research at university. The majority of it is never implemented. And the other thing is, if it is implemented, it takes about 20 years. So when you get a grant from the NHR, they're expecting you now to have if it's found to be effective, they want your evidence implemented within 3 to 5 years. So that's a big ask for researchers now, but implementation science can do that. Secondly, it prevents wasteful spending on ineffective or poorly implemented care. So you remember what I was saying? You may have a really good evidence-based intervention, but if it's not implemented well, you will never know if the intervention is effective, so therefore it never be put into practice. What it just says is the organizations can't implement it. And that's happening with our study at the minute. And I'll try and explain to you why we think that is. And like I'm saying to you, implementation science explains success, but it also helps you to understand failure. Why is it it's not being implemented? It improves acceptability, adoption, fidelity, and sustainability. It identifies your barriers and enablers to change, and it promotes inclusion, equity, and relevance. Okay, so it's very, very important that we start to see implementation science in all health and social care. We're also working with that education as well. I have a colleague in Limerick who's also a professor of implementation science, and she's doing a lot of work in Limerick around poverty, housing, and criminality using implementation science. So here's hopefully now you've had all that academic 20-minute, 15-minute stuff about the what is it and whatever. But here's a real life study, right? So we got funded in 2022 by the NHR for £2.1 million to do a randomized controlled trial. Adults with learning disability with type 2 diabetes. We needed to get 450 adults in Northern Ireland, Scotland, and England. They were going to be randomized. Half got an education program and half got nothing. Just got a booklet. So I don't know if you've heard of Desmond. If you or I were to go to our GP with type 2 diabetes, the doctor would send you on an education program for 6 hours called Desmond, shown to work in the general population and rolled out across the whole of the UK, Germany, Australia, and New Zealand. They're using this same program. Desmond is for type 2 diabetes, and you may have heard of Daphne, which is type 1, and it's a 5-day program, okay, given at a hospital. But these programs help you to self-manage your diabetes, and in the long term, you don't have as much complications, and therefore you cost less in the National Health Service. And that's why money is spent on rolling out these programs, and there's lots of educators. We took Desmond in 2015 for 3 years. We got a Diabetes UK grant of £300,000, and we adapted it for people with learning disabilities. It's a 9-week education program now. We called it ID, intellectual disability, because we were so original and so creative. We couldn't think of nothing what else to call it. So it's called Desmond ID. Desmond has also been adapted for different populations in England as well. Listen, I'm a researcher. I'm a realist. I thought, my God, 450 people with diabetes. How hard would it be to get this sort of population? Given that there's 1.5 million people with a learning disability in Northern Ireland, and between about 15% probably has type 2 diabetes, if not more. So how hard is it? So we had problems. So our study recruitment period finished in October last year, and off the 450, we were only able to get 265. So from a statistical point of view, we were never going to be powered to find anything effective. So the question is, Is Desmond for people with learning disabilities effective? Whoever knows, because we didn't find it. So we were very sad. You imagine getting £2.1 million and not finding anything. So we sat down, the research staff sat down, and we thought, what are the problems? What's happened here? What has really went on? So the first thing what we found was that there was 11 sites, 5 in Northern Ireland, 3 in Scotland, that's it, and 3 in England. And some of these cities had populations of 4,000 people with learning disabilities. Okay? If you just take 10%, that's 400 people with learning disabilities and type 2 diabetes. We were only able to recruit 7 people. And that cost £500,000. Now, this didn't happen once, this happened several times. Or we only recruited 15 people. So another site did very, very well. We only needed to recruit 36 per site. That's all we needed. So we started to interview some of the senior management in the learning disability team. And what we found was that for some sites, diabetes wasn't a priority. In fact, one senior manager said, "Oh, no. Diabetes isn't a problem. It's constipation." Now, I have no difficulty. I'm sure constipation is a problem. But for them to say diabetes isn't a problem is quite worrying. It wasn't a priority area. So senior management didn't prioritize this with their staff. And like I'm saying to you, we had great difficulties with buy-in. Some sites we couldn't get buy-in from their senior management. One senior consultant said, "No, people with learning disabilities couldn't do a randomized control trial. So why would I waste my time getting my staff to recruit people?" On other sites, we had great buy-in. So we're talking sites here. We're talking nothing to do with people with learning disability yet. We're just talking at an organizational level. And then whenever you did have a site that was brought in, some senior management didn't communicate very well with the study. You know, from the frontline nurses, daycare workers, social workers, residential staff, the communication was very poor. And instead of working with our time scale, the time scales extended for months and months and months just to recruit 36 people. Other sites recruited within the 4 months time period. A classic example was the sites, when we got down to the nurses and the social workers and the daycare workers and the residential workers, we said to them, right, how many people meet the inclusion criterion? And one of the nurses said 10. I said, happy days, that's brilliant, really, really good, 10 people. We only need 36. How many information packs did you send out? 4? 4? I said, well, what happened to the other 6 people? Well, number 1, she's too old. Right. I said, what age? Well, she's 63. We don't have an upper age limit. He's too grumpy. Now, I've never seen grumpy as an exclusion criterion. Number 3, mum and dad don't have transport, but we were paying transport from anywhere in the UK to a venue. Sometimes it costs £70, £100 if they live in the country, but we paid that because we knew that was the challenge. Another one was, no, she just wouldn't take part. So staff, professional learning disability staff, were making subjective bias statements. They wouldn't allow people the opportunity to engage in a trial. Now, you see, whenever we got to people with learning disability, we got 95% recruitment. You would never get that on a general trial. So there's a whole lot of bias in staff. Whether it's paternalistic, we're not sure. Or whether they don't understand randomized control trials and randomization. We had big issues around educators. We were looking for 2 learning disability nurses and 2 diabetic nurses. In the whole of the UK, do you know how many diabetic nurses we got? Or diabetes nurses? None. They just didn't see learning disability. That was part of their job. You know, and then other sites couldn't even identify enough learning disability nurses. We knew there was transport challenges at the fixed routines of this population. That was fine. And then when we looked at residential workers within supported living schemes and staff and residential homes, there was a commitment, but that faded very quickly. So whenever the taxi came, that we provided transport, some staff just put the person with learning disability in the taxi and said, bye-bye, see you in 2 hours. Then if some staff did come, it wasn't the same staff every week. So how was that learning over the 9-week education programme implemented during the week? We don't know. So the research staff and I sat there, we thought about this, and we started to look at an implementation, some of the implementation theories, doesn't really matter which one at the minute, but we started to look at what are the organisational barriers. This is a paper we published. So we started to look at this. This is called CFIR, the Consolidated Framework for Implementation Science, and it looked at 5 things. The outer setting, what goes on in the bigger world of the person with learning disability, what goes on and where the person lives, whether that's their family home, residential home, day centre, wherever. We started to look at people with learning disabilities. Was there any barriers? What about the intervention itself? It was 9 weeks. And then what about the process? And we started to look at just one area. We just looked at the inner setting. And we mapped that on to our challenges. And those yellow is what comes up in the challenges in the inner setting. So this was nothing to do with people with learning disability at this stage. This was to do with senior management, frontline professional learning disability staff. And that bottom one should be ticked as well, the commitment. So we knew we had challenges. And we thought, well, what are we going to do? We just got it, by the way, we've just got another £300,000 to recruit another 100 people from Greater Manchester. Fingers crossed. We've just started to, actually the staff are going over tomorrow to see if we can identify people. But we needed to address some of these barriers. So, but before we did that, we started to look at which sites did well and which sites did poor. And there just happened to be 5 sites who were able to recruit on average 34. Their readiness, what's called organisational readiness, was really, really positive. Great buy-in from managers. Managers communicated to their senior management team, to the frontline nurses. They met with us every week, not a problem. They were on the ball. It just happened to be with local champions. There was learning disability nurse consultants. They took the role on, the role this study out, and they were able to recruit. For learning disability nurses, not a problem, as I was saying. But then if you looked at the sites that didn't engage, there's a middle one, but 4 sites there, 4 sites could only recruit between 7 and 15 people. They weren't engaging with us. We had little buy-in from the managers, poor communication with frontline staff. When we asked for meetings, they were asking, could we have an extension, or they didn't turn up, or nothing was prepared. They had no champions leading this. It was all very vague. All started really well at the start. And then when we actually started to do the study, it just faded away. And they only could recruit 2 nurses, but we needed 4. So this is just us looking back. We wrote a paper on it now, obviously. But this is us trying to think about, these are organisational barriers that is stopping the evidence. At this stage, we're still testing the evidence, but we had an evidence-based intervention called Desmond, which we have adapted, and we wanted to evaluate it. But the difficulty is these organisational barriers were going to limit if it was going to be effective. And in fact, because of the organisational barriers, we couldn't recruit enough people. And that's why we're looking at implementation science now and seeing what we can do. So whenever you have these barriers, there are strategies that you can do. Some of these strategies have been identified and shown to work by other people. Some strategies you may have and you may need to adapt to suit your population, suit your context, and you may, particularly in the field of learning disability, you may need to develop new strategies. So there's work's been going on for a number of years looking at, well, what would those strategies be? And this is the work of Eric Powell in 2015 called EiPSIG. What does it stand for? Expert implementation something, I can't remember, strategies, but they've grouped them into 9 categories: evaluation and narrative strategies, interactive assistance, adapt and tailor, change, develop stakeholder relationships, train and educate, support clinicians, Can't move in the wee box. Engage consumers and financial strategies. So we knew, we were thinking now, just in relation to CIFR and the inner setting, the organisations, we knew what we needed to do by looking at this. So identify and prepare champions, the learning disability consultants, organise clinical implementation meetings. Now that's different. We do have clinical meetings for the trial, but this is specifically implementation. So who in the organisation do you need to have to make the change happen? So people from policy, finance, senior management, that was really important. We've been doing a lot of work with Manchester since about before Easter, but we only started there a couple of weeks ago. Does it took that long to get that? But I mean, Manchester was really well ready compared to some other sites. And again, capturing and sharing local information. They've been working with GPs for months. And also we were able to get them to visit other sites, good sites that were in the green. You know, there's lots of strategies there. I mean, obviously we do training as well. We already were doing that. But this is from some of the barriers. We never thought, in the life of me, I always thought it would be people with learning disabilities. That would be the challenge. And I've worked in this field for 30 years. This is a totally different game. And this is why this paper came around here at the bottom. Who presents the greatest challenge? Sorry, I just had to move my camera. Really thing. Hold on 1 second. In intellectual disability research, is it the participants or is it healthcare professionals? You know, and this is why if we had embedded implementation science and looked at organizational readiness, we could have counteracted some of those problems. So if we had assessed organizational readiness, those 5 sites that were in the green here, if we had a look, those five sites were ready, and there's no doubt about it, they were ready in close Greater Manchester, and then those other sites weren't. And as we were reflecting, it just happened to be the 5 sites that were all ready were in Northern Ireland. And it is probably, you know, as my staff would say, it's probably me, because I've been around for 30 years. I know everybody, but it's not just about that. It's about trust, relationship, and communication. And that's a big part of implementation science. The other sites in Scotland and England, they were coming out of COVID. We couldn't get to do any physical team meetings. They wouldn't allow us. My motto is, when you start to do a research project, you go to Marks and Spencer's, you get your finest coffee and your buns, and you meet the team as often as you can, and you win that staff over. That's what you have to do. But I know we were going to come over and visit. No, all our meetings are on Teams. That's not that helpful. So so you've got the whole issue around what is implementation science. Then you've got this problem. Okay, now the question is, going forward, let's say if we find the intervention works, how do we implement it? So we have a pathway. So this normally what happens, right? Normally in research, what happens is you take the thing that works, the evidence, the policy, the technology, and then we measure it against patient outcomes and service outcomes. That's the way an RCT would work. But if you now add in implementation, what you now have is you now identify these barriers a lot earlier and the enablers. And now what you say is, right, we know in this context, and you could be looking at whatever 20 contacts, 15, it doesn't really make a difference. But you go in, you do a lot of qualitative research, there's some questionnaires, you actually find out what are the barriers or enablers to implementing the thing you want to implement. When you've identified your barriers, as I was saying, you then identify your implementation strategies. And these are methods or techniques used to enhance the adoption, the implementation, and sustainability of the thing you want to implement. And then you end up with also looking at implementation outcomes, because not only do we want to look at does the intervention work, we also want to test, do the implementation strategies work as well? You're testing 2 things. So we're moving away from a randomized controlled trial to a new thing, what's called a hybrid trial. And that basically tests, does the intervention work and does the implementation strategies work in your context? And that's basically like a pathway to implementation. The proper name for that is an implementation research logic model, but who the hell would know what that means? So we just call it a pathway. It keeps it nice and simple. And that's, in a summary, what implementation science is, without the theories and the models and the frameworks. That's what we try and do. We try and now and sit down and we do it. Like, for example, we have my PhD student, Gary, he developed, have you heard of HIT, high intensity interval training? Well, he's adapted that for adolescents with learning disability and autism in special schools in Northern Ireland. He's doing a feasibility randomized controlled trial. We got £100,000 from Billy Thomas, and he actually is assessed. He's done this. He's actually went into 8 schools. May he gave out the questionnaire, and in June he did focus groups with the principals, the PE teachers, and the classroom assistants, just to see can they implement the thing. And here, and like now, I know today he's away to Park School in Lisburn. That's randomised to the intervention. He's away to there to do some co-production over the next few months. They get the school ready, they get the implementation strategy, and then in the new year we roll out the program. We measure all these 3 things as well. And that means then when we go to the full trial, we can build in implementation strategies into the full trial. And we know that these strategies, seem to be acceptable to the school and can be measurable. So the question is then, so the benefits of implementation strategies, it increases feasibility of delivering the thing in routine practice. It supports long-term embedding and sustainability of the thing in the routine practice, and it promotes equitable access and quality of care. So the last just couple of slides, and I'm going to shut up, is what's our role in implementation science? So we all have a part to play. It doesn't matter where you are in that spectrum. You've started to hear about the importance, and I just gently mentioned that to you. Very easy to collect that sort of information. What are the barriers and enablers to implementing a potential bit of evidence? And you've also started to hear about the importance of potential implementation strategies. Some of those you do every day anyway, but it's just being that more systematic and measuring whether they work or not. So where do we start? Very quickly, there's a lovely model by Alison Metz in 2020 called the hexagon model. It's very user-friendly. First of all, you just need to say, okay, does an organization recognize the needs? And I'm just taking this case. We were doing work in the Southern Trust around older family carers and older people with learning disability. So the question is, does an organization identify there's a problem? Do they understand there's a need? So if we had went back to our diabetes study and if 6 sites said, oh, no, we have no problem, like there's no problems with diabetes, it's not an issue for us. But we need to do something quickly here. We need to get them to try and understand the whole issue of what is diabetes and people with learning disability and the barriers. So is there a need? That's the first thing. Secondly, do they know what an evidence-informed research is? Can they identify, or should we be looking at what type of specific interventions there are? So they get a feel of this is something that we could take on. We could take ownership of this rather than just saying, here, I have a brilliant intervention, you must implement it. That's never going to work. Again, how well will local services, your team or whatever it is, how will that evidence fit within the service? They need to say, yes, we can make it a priority. Yes, we think it would really meet our some of our needs and some of our population, and we think the outcomes could really be beneficial. So they can see a benefit to engaging with it. Is the organization ready? In relation to resources, in relation to finance, in relation to staff capacity and capability. Now, we've done this before, and a lot of our studies are coming out around it is difficult to work with, as I said, learning disability staff. And it's not that staff don't want to be cooperative. It's to say that staff are working in broken systems, where there's not enough staff to work in a system, or there's not enough people on a shift. Or some of the other people with learning disabilities in the field that I work in, may have behaviours that challenge and they need to have staff on the ground, you know. So it's really asking, can organisations deliver on what's being asked to implement it? Even things like, can you identify learning disability nurses? You know, the sites couldn't even do that. Again, like I'm saying, what are the resources and the supports that need to be available to implement the new evidence? And again, staff capacity and capability. This is a really lovely model that you can get an organ. And again, all this is done through co-production. You sit down with the team. The team's just not the senior management. Sorry, it's not the middleman. It's senior people as well. It's those people. You need to think about who are the people can help you implement the evidence, can help you with resources, capacity, capability, because sometimes you have to interrupt what you do because you can't keep asking staff to do more and more and more. My wife's a principal. She keeps telling me, get lost. We're not doing no implementation science for you. You know, she just says we can't do anymore, but yet the Department of Education asks us more and more and more. And then an email came around last week saying, don't recruit, don't hire any more, what do you call them, locum staff, just we don't have the money. So how can they do their own job if they can't get enough subs in? Anyway, look, listen, that's more or less, I know it was a quick, this is it in a wee bit more detail. I'll pass the slides to you, and that's the reference. So the only last slide is to say implementation helps us to understand the complexity. You know, it's not just simple to say, here's an intervention and here's the outcome. There's a whole lot of other complexity, not only with your population, and we think, you know, we adapted the intervention for people with learning disability. The only problem now is we're struggling to implement it to show that it works. So take some questions. I'll stop sharing, or maybe you want to. It's up to you. Well, I don't know how you found it. I get excited by it. Obviously, as you can see, it's my new baby. So it used to be a logic model. Now it's implementation science logic models.
Yeah. Great. Thank you so much, Lawrence. The floor is open for questions.